AHLA is pleased to present this special series highlighting the top 10 health law issues of 2022, where we bring together thought leaders from across the health law field to discuss the major trends and developments of the year. Support for AHLA in this series is provided by PYA, which helps clients find value in the complex challenges related to mergers and acquisitions, clinical integrations, regulatory compliance, business valuations and fair market value assessments, and tax and assurance. For more information, visit pyapc.com.
Thank you for joining us with AHLA's Top 10 Issues in Health Law for 2022. Excited to bring up the rear at the last of these sessions for the 10th session. I'm Valerie Rock. I'm with PYA. I'm a principal with PYA and in our compliance department, and I oversee our revenue integrity services. And today we're going to be talking about APPs and the expansion of those APPs utilization as it relates to COVID and how that might be a pathway forward for continued expansion of those APPs. So today I have the author of the article for the top 10 article, Robin Nagel. She's with Post & Schnell, so I'll let her introduce herself as well.
Hello, everyone, and thank you, Valerie. I'm Robin Nagel. I practice healthcare law with Post & Shell in Philadelphia, and I have a healthcare regulatory and compliance practice, and I also work a lot in medical staff and privilege issues, but definitely a good component of my work relates to advanced practice professionals and the various settings in which they practice. So I'm very happy to be here today.
Great, thank you, Robin. So we are going to talk about APPs today and want to make sure that we're all on the same page on what an APP is. So you heard Robin say advanced practice professional. You might hear advanced practice practitioner or provider, but you also may hear them called non-physician practitioners. Medicare calls them that. So when we're talking about these guidances today, if you're looking for that within the Medicare manual, you want to make sure that you're looking up NPP or non-physician practitioner, not APP. That can be a little confusing. We've had lots of different terminology to call nurse practitioners, physician assistants, and other allied professionals. So we want to make sure we're talking about the same thing, but today that's who we're talking about, the non-physician practitioners that are serving our patients and are really our future for addressing physician shortages that are anticipated. So we want to make sure that we're looking at how these trends might be moving forward as it relates to COVID, since we've had some expansion there. So to kick things off, in what way, Robin, have you seen COVID has presented an opportunity to advance the practitioners within the industry?
Sure. Well, with obviously the federal and state emergency declarations and COVID waivers, as with every other facet of the healthcare industry, we just launched into an all hands on deck environment where the goal was to facilitate as much care as reasonably can be provided in every setting where it can be provided, keeping patients out of hospital as one of the top priorities. And in that environment, there was a relaxation of a number of the traditional restrictions on APP practice, things like supervision requirements, location requirements, where they can practice, how they can practice, obviously going into patients' homes and across state boundaries. We saw, of course, a great expansion in the use of telehealth, not only by physicians, but by all kinds of APPs practicing now across state lines. And really, one of the primary goals and opportunities was to relieve the burden on physicians for the primary care services that advanced practice professionals do very well. And I think that as part of that, they were able to demonstrate, the quality and efficiency of their services in doing that.
Sure. So were there studies done along the way during COVID that helped demonstrate APP capabilities?
Well, there have been numerous studies over the past several years that have demonstrated that For instance, CRNPs and PAs can provide primary care services at the level of quality and efficiency that is at least equal to what physicians can provide. And also that they can be effectively deployed, particularly in areas of where physician access is limited. I would say during COVID, there have been studies and reviews done. They're necessarily more anecdotal because we're in the middle of a global pandemic, but they've highlighted that the waivers that allowed APPs to practice at the top of their licensure, evaluating, diagnosing, ordering, prescribing, and managing care in less restrictive environments really provided an opportunity to generate powerful evidence of their capabilities. I noted that Health Affairs in a COVID-related thought piece that was really focused on the challenges of physician practice in the COVID environment pointed out that APPs can help relieve the burden on physicians and reduce physician burnout, which itself can cause medical errors and safety issues. So recognizing that the ability of APPs to kind of expand the reach, particularly in that primary care setting or environment, is helping to relieve the burden on the higher level practitioners.
Sure. So what challenges lie ahead for APPs during a post-COVID environment?
Well, of course, with the ending of the emergency declaration and waivers, as with every other aspect of the medical industry, APPs are being thrust back into the same restrictive practice environment that existed pre-COVID. And there are significant restrictions to APP practice. The barriers that exist and by the way, these are very, very state specific. So you really have to look at what's going on in each of the individual states. But in many states, they're still CRNPs and PAs are still required to practice pursuant to supervision agreements or potentially the somewhat less restrictive collaboration agreement where you don't have direct supervision and responsibility by the physician, but you still have to have a kind of collaborative environment where you are consulting and they are kind of paying attention to what the APP is doing. One of the things that I know that APPs have pointed out as somewhat restrictive are the fact that still in many states, their practice is regulated by medical boards, that is physicians and osteopaths, licensing and overseeing the scope of practice of APPs. And there is an argument that is being made that you would really have a more effective oversight authority if it's made up of folks that are in the practice, are really personally familiar with the capabilities, the training, the scope of practice that APPs are capable of. And also, let's face it, there's a concern that if APP practice continues to be regulated by medical boards, there's a certain amount of competitive or anti-competitive animus that might have a tendency towards keeping that practice more restrictive. So those are limitations that exist. Limitations obviously on billing and owning one's own practice, unless APPs can really be able to provide the service independently, bill for the service, collect the revenues, and own and manage their own practices, they are going to continue to be somewhat beholden, to the physician industry. Things like signature requirements on orders, prescriptions, records, all of these things hamper the day-to-day functioning of APPs, and those clearly still exist post-COVID.
Right. It does seem like a challenge because if there is not some level of oversight, because clearly PAs and NPs don't have the same education exactly as a physician, so there's kind of like a tug, a push and pull to that needs to be overcome at some level to allow those PAs and NPs to practice independently. It's interesting that it may be the physicians themselves that kind of hold that back because of that feeling like they're taking over the same space. So hopefully we can overcome that because there is a need, right, for those APPs to have that ability to see those patients, or else we will have a shortage. So hopefully we can get everybody aligned. So are there any signs that COVID has provided an impetus for more permanent change?
Well, I think there's been a lot of movement at the state level, and of course, it has to happen predominantly at the state level in terms of licensure and scope of practice. So we are seeing laws passed just in the past year in various states, relaxing supervision and collaboration requirements, expanding scope of practice, eliminating some of the counter-signature burdens, and so forth. And so, yes, I think there are some significant gains that have been made. In the area of CRNPs, for example, just to give a few examples.
Sure.
So I talked about the licensing board, versus the nursing board, the medical board. So Delaware this year moved to the licensing authority for CRNPs from the Board of Medicine to the Board of Nursing. That's seen as a step forward. Massachusetts granted full practice authority to CRNPs, and they passed emergency regulations this year that, for instance, allow CRNPs, psychiatric nurse, mental health clinical specialists, and other nurse practitioners to prescribe without supervision, that is to prescribe medication without supervision after they've gone through an initial 2 years of supervised practice. So you go through the initial period and then you move into independent practice. Arkansas authorized a pathway for full independent practice for qualified nurse practitioners. They have to complete about 6,000 hours of supervised practice under a collaborative agreement with a physician, but then they can move into independent practice. And a similar path for certified nurse midwives. One caveat there, the law permits them to prescribe Schedule II controlled substances, but only with a collaborative agreement. So if they want to have that ability, they're going to have a collaborative agreement in place for that. Illinois, and just sort of reflecting the pandemic environment that we're in, Illinois and Oklahoma passed laws authorizing APRNs to complete death certificates. And a new Louisiana law authorizes psychiatric mental health nurse practitioners who are practicing pursuant to a collaborative agreement to make the decision or to order voluntary admission or to certify for emergency admission patients for psych treatment facilities. So those are a number of examples where laws have been passed that are recognizing, the capability of allowing this greater scope of practice for nurse practitioners.
That's great. We've definitely seen some real push forward, even in the telehealth space, in regards to access to care for mental health issues. So that's been a good trend. So allowing those PAs and NPs to provide services in that area is also excellent to see. What about other ways that PAs have had gains in this area?
So, there are a number of states that have passed legislation authorizing increased PA practice. Tennessee, I mentioned Delaware creating the Board of Nursing for licensure of CRNPs. Tennessee passed a similar law, taking licensure for PAs from a committee of the medical board and instead putting it under a board of PAs to supervise that. Oregon moved from PA supervision agreements to collaborative agreements, which again, as I said before, are less restrictive. And it also relaxed requirements relating to PA dispensing medications and made some permanent, you mentioned telehealth, and Oregon has basically aligned PA ability to do telehealth to match that of physicians. And they do have good laws already on the books, allowing physicians and now PAs to be practicing telehealth, to be practicing across state lines, to make the licensure issues more manageable. Those are very positive developments. Florida made a number of changes for PA practice. The ability to prescribe and dispense prescription medications, to authenticate documents, to supervise medical assistants, so PAs supervising MAs. They also modernized the education and training requirements in a variety of respects. And so having relaxed some of those supervision requirements, they then also increased the number of PAs that a physician can supervise from 4 to 10. So you still need the supervision agreement, but the physician can now supervise more PAs because the supervision requirements are somewhat relaxed. Similar thing happened in Washington State. They increased the supervision ratio from 5 to 10 physician to PA. They also, another element of what they did in Washington was to eliminate the requirement of approval of the supervision agreement. Still need supervision agreement, but you no longer have to get the Washington Commission approval of that agreement. Pennsylvania likewise removed the board, it's still a medical board, but the medical board approval of PA supervision agreements. You still have to file them with the board, but they no longer have to approve them. And they created more flexibility in terms of counter signature requirements. For instance, the PA and the physician for the first 2 years of practice, physician actually has to review and sign off on 100% of the PA's records. But after that first 2 years, the physician and the PA can decide what they think is the appropriate amount of review and counter signature on a go forward basis. So, after that initial period, it allows for a lot more flexibility. All of these things on one level could be seen as kind of baby steps towards, the goal that the APs have of full independent practice. But I do think that we've seen a number of gains in the past year and that each one helps create momentum for future changes.
Absolutely. So we talked about kind of the regulatory aspect. What about the billing and payment aspects?
So I'm going to start by flipping this back to you because I know that you are a billing and coding expert and that you've worked very, very significantly in the PA space. From chatting before, I know that you have some concerns about the new Medicare requirements. So why don't you talk a little bit about that?
Sure. So as you know, or some people may or may not know, there's been a change or shift in guidance in regards to the way that you bill and select an E&M code, an evaluation and management code, starting in 2021. Based on that change, the shared visit guidance and the critical care guidance that were in the Medicare manual no longer made sense, and they were no longer aligned with that new guidance. So there was a petition by physicians and other providers that said that needs to be removed. We need to revisit this. Let's get this aligned. So in 2022, in the fee schedule, Medicare physician fee schedule for 2022, it was finalized that the way that you select the level of service for a scenario when you have an APP and a physician doing a service on the same day, so shared visits in a facility setting, that you would use whoever provided more than 50% of the time. That is the provider, the billing provider for the claim. So in most cases, we know that APPs are usually the ones that go in, they get all the data, they're gathering the information on the patient, they're making sure that they are looking through the history, looking through the exam components, kind of doing that preliminary medical decision making. And from that, the physician takes that information and then makes some decisions about it and may get clarification on some exam elements, some history elements and things like that, and then make a decision on the medical decision making and assessment and plan. So in a majority of cases, you would have an APP doing a majority of the time for that scenario. In 2021 and up to 2021, you would have billed that shared visit in a hospital setting, facility setting, under the physician. But now, based on these new guidelines, you would be billing that under the APP. Now we know physicians get 100% of the fee schedule and APPs get 85% of the fee schedule from a reimbursement perspective. That means that either there's probably going to be a shift in patient flow, or the physician is going to say, well, I'm just going to take more time to see this patient. There's going to be some kind of shift because we've kind of pulled away the reason to use these APPs. If we're going to reduce the total amount of reimbursement by 15%, for the same service in 2021 and previous to that. So it is going to be a real challenge to see how this moves forward, but this is an example of changing the guidance that might have sounded like a good idea, where you're going to treat the APPs as a part of that physician group and pull them all together and bill under one provider and bill under the predominant provider. That sounds good until you realize it's going to be a 15% reduction. In addition to that, physicians are often paid on work RVUs. So now if the bill is going out under the APP instead of the physician, now the physician comp model is no longer, it no longer works, because now you don't know how much that physician work was associated with that service. The physician is basically lost from the data. So it is going to be a challenge, and I think it goes against the APP utilization, not for their utilization. And so I'm concerned about that it's going to flip in the wrong direction. So I do recommend getting on the phone to CMS and others, people that represent you within CMS and your MACs about this, and try to figure out a way that it's going, for a good solution to this, because I don't know that this is a step in the right direction. An additional area that we've seen things kind of moving forward is that credentialing for private payers has increased for APPs. A lot of them are credentialing now, whereas in the past they have not credentialed. So now when we go into a physician practice, oftentimes they're saying, yes, we credential our APPs and we don't bill incident to anymore, that we just bill under the APP when they're doing service, which is great, which is getting back to that top of license kind of scenario where the APP can do an independent service, bill under his or her number and be done with it, versus trying to kind of finagle it to end up under the physician. So we are seeing some trending forward there, but again, one guidance in the wrong direction can kind of bring us steps back instead of steps forward.
Yeah, and I think that what you're pointing out is that it is so much more complex, I think, in the institutional environment, where you have physicians and APPs and nurses and other staff just working side by side, and sorting all of that out from a billing perspective creates a number of challenges, and as you pointed out, perhaps some workflow issues as well. I do think that where I see a lot of in terms of the expansion of practice, or the enlargement of the scope of practice being most effective, I think, is on the outpatient side, particularly where APPs can fill in the gaps that are left, because we just can't have physicians in every rural county, in all of the underserved areas. And I think that that's a place where APPs in particular can demonstrate their important worth. An example of that from a billing perspective is Arkansas. So they just passed a Medicaid law in the past year that has expanded the authority of APRNs to provide direct family medicine practices, to actually have their own family medicine practices. So they are now recognized as primary care providers and team leaders of family practice professionals and patient-centered medical homes. And the law requires the Medicaid program to reimburse APRNs for ancillary services such as labs, x-rays, and other tests. So it really does sort of help promote that idea of an independent practice at the APRN level that is capable of providing primary care services and billing for them.
Great. So bringing this kind of all together, looking to the future, what do you see as the path forward for APPs seeking to capitalize on gains made during COVID?
Well, of course, the various APP groups, be it physician assistants, CRNPs, or others, they all are pretty active in lobbying at the federal and the state level. And I'm sure those lobbying efforts are going to continue, through 2022 and beyond. As one example of that, the American Academy of Physician Associates, or AAPA, these are PAs, they've sort of developed a target or a program that they call optimal team practice. And what they mean by that is a future state in which PAs practice alongside physicians and other healthcare professionals, as sort of equal members of the team without what they call, quote, burdensome administrative constraints that limit their practice. So, this translates into three concrete goals that they have. One is the elimination of the physician supervision and collaboration requirements. So they'd like to be able to practice completely on their own. And as you pointed out, there's a push and pull to that, because I think we all recognize that there's certainly, an important role for physicians in that relationship. The second one is to create, as I've mentioned a couple of times, PA boards to actually do the licensing and regulate the practice of PAs, so that they're not a cousin of the physician boards. And then the third is to authorize PAs to be eligible for direct payment for all public and private insurers. So they're very lofty goals. We're very, very far from seeing that happen in the real world. But, I think just looking back over what happened during COVID and what's happened over 2021, they can point to specific laws that have been passed that are, beginning to move them in that direction. And I would expect that trend will continue into and through 2022 and really beyond.
Great. Well, thank you, Robin. Really appreciate your time today and sharing with us in regards to this potential expansion, kind of a silver lining on COVID, maybe, that we can take from this. And thank you, AHLA, for hosting these podcasts. Really appreciate your efforts for getting this information out there so that we can all learn from what's going on as we head into 2022. So thank you all for your time today, and have a great day.